My name is Dr. Al-Khalaf, a research fellow here at the University of Ottawa Heart Institute, and I am back for today's episode of BEaTS Research Radio, a YouTube channel and podcast produced by the Bioengineering and Therapeutic Solutions Lab at the University of Ottawa Heart Institute. Our goal at BEaTS Research Radio is to communicate science to the community. Our guest today is Dr. Christina L. Dr. Luong is a clinical assistant professor within the Division of Cardiology at the University of British Columbia, and she is the head of stress echocardiography at Vancouver General Hospital. Dr. Luong obtained her Doctor of Medicine degree at the University of Alberta and subsequently trained in internal medicine and clinical cardiology at the University of British Columbia. She is a fellow of the Royal College of Physicians and Surgeons of Canada, and her primary scholarly focus is on cardiac imaging and ultrasound, with emphasis on artificial intelligence and machine learning. Thank you so much for joining us today at BEaTS Research Radio, Dr. Luong.
All right, thanks for having me.
Absolutely, it's our pleasure to have you. To start, as a cardiologist and echocardiographer, can you tell us how you came to focus your pursuit into these medical specialties?
So, I mean, in terms of my kind of career trajectory, I had done quite a bit of research as a medical student and undergraduate student, and I think it was maybe serendipitous that I ended up in different labs that had extremely inspiring mentors that kind of guided me towards the field of cardiovascular medicine in general. And actually, one of the University of Ottawa professors, Dr. Bernard Thibault, happens to be a mentor that I had back in the University of Alberta when he was here, when I was an undergraduate student, and it kind of led me towards the pathway of obviously cardiovascular medicine, although he's a neonatologist, but his area of research was pulmonary hypertension in neonates, and so it kind of led me in that pathway. And then kind of along the way in training, I had excellent training and mentors in cardiology as well as in echocardiography, even as a cardiology fellow. And through these kind of relationships and interactions, there's recommendations as to kind of the direction of the field and different research opportunities, and that kind of opens up doors in that way. Stress echo is obviously very interesting from a clinical point of view for me, and it's an area that was kind of a need in my local hospital, as well as kind of interesting directions with regards to like stress diastology and in relation to heart failure with preserved ejection fraction, but also the research aspects were with machine learning is the opportunity arose because UBC had a very robust kind of computer science and biomedical engineering group that collaborates very closely with our group. And so I work closely with Teresa Sang, who's been my mentor throughout my medical as well as my research training at UBC. And so it kind of, there's innate interest obviously, but also interest that kind of is nurtured by mentors and different opportunities.
Yes, it's finding mentors along the way and networking through that is definitely one of the ways in which we carve up our careers. One of the current areas of academic and clinical translation work is related to a novel type of cardiac handheld ultrasound instrumentation, which has given rise to what is referred to as point-of-care ultrasound, or Pocus. Can you briefly describe this method of medical care?
So point of care ultrasound is not a new thing. Lots of different applications have been used in the past, usually outside of the cardiac or cardiovascular realm, just because it was used by emergency physicians and surgeons and intensivists for things like procedure guidance and whatnot. And that's been kind of the standard of care now for things like insertion of central venous catheters and whatnot. But recently, because there's like an explosion in terms of the number of potential devices that are available, the size of the devices, they're now pocket size, and there's numerous different vendors, and the price points has come down significantly. And it's become integrated as part of medical training and in medical school, as well as in residency. And so this kind of procedure is basically regarded now as an extension of the physical exam, where you basically have an additional tool that you can perform at the bedside in a limited scope to answer kind of yes or no questions for from say, I guess from a cardiac point of view, I'll say, things like pericardial effusion, LV dysfunction, and volume status that can help triage patients and guide therapy. And there's a lot of interest in this area because it's becoming, a wide scope in terms of the type of providers that will use it. And so it's not a new area, but I think there's kind of some new aspects about archiving and how it's used and what the limitations are and what kind of training or certification, if anything, that's required. And so it's an exciting area. And I guess I'm interested from a clinical point of view to some extent. And I'm part of the Canadian Society of Echo Pocus, like cardiac Pocus committee, and along with Amar George, who is a leader in this area, and kind of whether or not this can be applied in some way with regards to machine learning related models to kind of help with things like interpretation or image augmentation with people that are not necessarily echocardiographers or cardiologists that have formalized training.
So that actually brings me to a question regarding Pocus. To what extent is the use of Pocus limited to trained echocardiographers as compared to maybe a more novice user of this technology?
So I would probably refer you to a new guideline document that came out from the American Society of Echo within the last year, with representation from a Canadian point of view by Amar George as well. But I think just in general, the kind of I guess it's kind of important to recognize that there is a difference between echocardiography and point of care ultrasound or cardiac point of care ultrasound. Echocardiography is technically considered like a diagnostic study. There's certain technical in terms of machine related expectations as well as interpretation expectations for that. And it's usually performed by somebody that has specific training and certification that is appropriate for that kind of exam. Pocus, on the other hand, is a range in terms of what's considered acceptable or within the scope of practice. And so Pocus can be a non-traditional interpreter performing the exam on a full functionality machine. So that could be if it's a intensivist or like an emergency physician performing a limited study on a full functionality platform echo machine, or it could be potentially a cardiologist performing it with a limited functionality platform. So it would be like a handheld device. So I think if an echocardiographer were to perform it on like a handheld device, that's still considered Pocus. However, if you as an echocardiographer or a cardiologist trained as a level 2 echocardiographer drag the full functionality machine over and take some images, that's probably considered a limited echo, where there's probably an expectation that if you saw something that's unusual that you would probably extend your exam or recognize that there is a need for additional pictures. And so it is a little bit of like a language type of difference, but Pocus can be performed by echocardiographers or non-traditional imagers as well. And there is an expectation that if you're doing it, you would kind of know what you're looking for or recognize when something additional images are needed or some additional help is needed. But if you're going to be using it as an extension of the physical exam, it is kind of something similar in terms of what the expectations are. Archiving is not necessarily a strict rule, but it is certainly encouraged.
Excellent. This is really great news. And I wonder if you can speak a little bit more on the, academic aspect there, the scholarly work on artificial intelligence and machine learning with respect to these types of readouts.
Yeah, so my research kind of is done in a partnership essentially with computer science and biomedical engineering at UBC. So obviously from a clinical point of view, I interpret echoes and I do clinical cardiology. But the part that I guess is interesting about the kind of research that we're doing is we do need the collaboration of machine learning specialists to help develop these models that will, in my kind of overall goal, assist in interpretation or acquisition of cardiac ultrasound or echo images. And it could be, I guess, formalized echo in terms of improving workflow or automating certain parts of measurements or certain parts of interpretation with some human oversight in the future. So, I mean, it would be like sort of semi-automated readout that you would have to overread, similar, not similar necessarily, but kind of in the same vein as potentially what you get for ECG reading. And then also potentially have this kind of technology applied to devices that are used for point of care ultrasound for non-traditional interpretation by kind of non-cardiologists or echocardiographers. So things like LVEF or regional wall motion abnormality or different kind of pathologies that might be picked up on in an appropriate setting. The role that I have in terms of this research relationship is, because we have the clinical expertise, it would be things like identifying the pathologies that would be part of the data processing and analysis, and then actually coming up with the research ideas that basically would be of clinical relevance. The biomedical engineers are experts within the machine learning field. And over time, I've kind of learned a little bit on the side too, but by no means was I ever going to become somebody that was going to do any of the programming. I think at my early stages, I thought maybe I would try to learn how to do it a little bit, but it's good to have a good working understanding from a clinician or clinical point of view because of the research aspect. But you're never gonna catch up enough to stay abreast of that kind of field. So we work kind of like in close partnership essentially. So we both need each other in order to advance these kind of projects.
Yeah, absolutely, and I share your early enthusiasm towards trying to do programming, and I share your realization.
After auditing a few courses, I realized that I was never going to really get there.
Yes, I definitely had the same type of realization, and I'm like, okay, I'll stick to my bench lab work, and I can coordinate.
Which area were you trying to learn?
Any kind of bioinformatics
yeah, right?
is basically beyond me.
No, it's like same as saying like learning advanced statistics, right? I mean, yes, I could do basic statistics, but I mean, I'm not going to be the one that's going to be doing the
This is why collaboration is the
complex clinical trials that
yes.
that requires many different steps, right? So I think the same kind of principle holds.
Absolutely. Now, I'm going to go into like maybe a little bit outside of the field here and ask your opinion maybe on the use and like proliferation of wearable technology that now seems to incorporate some of these health readouts and health measurements. And I wonder if you have a general comment about the introduction of this into the wider public use.
I think it's very exciting. I mean, the Apple Watch, I guess, is kind of like an interesting, like a obvious example, or some of these Fitbits that will detect abnormal rhythm. All these types of things are out there. They're all consumer products, and so there's a tremendous potential. And obviously, there's some risks and caveats that have to be put in there in terms of trying to get some of the data with regards to some of these very widely used devices for things like prediction of major events or other things to improve health. Sometimes they cause a little more trouble from the clinical side because people bring in things that are uninterpretable or you can't quite make sense of what has occurred based on the maybe imperfect data that is there. There's obviously a caveat on all these things that they're not medical devices. They say they're not medical devices and they basically are like kind of wash their hands of any liability. But there's some exciting collaborations that are coming out, and on October 8th, there was this announcement by Butterfly IQ, which is one of the handheld ultrasound devices, that there's a formal collaboration with the American College of Cardiology for research. They didn't quite say it, but they suggested that it would be for potential, say, heart failure. It'd be a heart failure study with potential for some kind of probe or device that would be used at home. So they're like, it's kind of a big step, because usually we think of these devices at home as like, heart rate or rhythm, or potentially like say that atrial fibrillation detection module as being there. But here they're actually potentially looking at some ultrasound related device. Maybe they're looking at lung B-lines or something. They never said what it was, but there's a lot of interest, and now that I think there's a formal relationship with the American College of Cardiology, it does suggest that the medical community is on board with this kind of technology. My opinion is I think it it will generally probably be helpful in the future, depending on how good these algorithms are, right? So if you have this kind of thing, these kind of technology out there, but it performs poorly, all you do is create a little bit of havoc in the medical system. But I think for the most part, because there's so much data, and now a lot of commercial entities are aware of and starting to get expertise for machine learning and these kind of approaches, I think these kind of algorithms will become better with time.
Yeah, actually, I remember in a recent meeting, I caught a session where they discussed the Apple Watch. I believe it was like an atrial fibrillation type of study where they said it was somewhere around less than 75% accurate in its detection, and that created
pretty conservative.
And that creates a lot of issues with patients.
Patients getting worried. They come in, they send you all their tracings. I haven't had too much of that. I've had some, and actually I had someone they showed me their tracing, and it was actually atrial fibrillation, but I was like, I don't know, I'm not exactly sure. And so I never really, I was like, why don't you do a 12-lead ECG for me at some point when this happens again? And we caught it for real within a week or two, and I was pretty happy. But if I hadn't, I would be lost in the situation where I would decide whether or not I really thought, because it wasn't necessarily atrial fibrillation, it looked like it could have been frequent PACs. So it's not clear to me what the fidelity in terms of showing the ECG tracings look like. And so, yes, it does create a little bit of issues. And I think the algorithm is relatively conservative. So I think anything over 100 beats a minute ends up getting called indeterminate. And that's for my own reading. So when I was pregnant and my heart rate was faster, it would give me lots of alerts, and they would all say indeterminate. And they were sinus because I could read it. But so I can imagine that if there was any situation like that, it would create a lot of problems.
Yeah, there's definitely some space and runway for artificial intelligence and machine learning to optimize these devices, and probably inevitably they will, and but we're still in the
sure, it's the medical liability thing. I think for any company is I think huge, right? So
yes,
they probably want to call these I can't quite recall what the classes are, but they want to call it a class like a non-diagnostic class of tool as opposed to a diagnostic class.
Absolutely. All right, so our last question for today, Dr. Luong, is what type of advice or words of wisdom could you share with early career professionals in general, or cardiologists more specifically, in order for them to better orient their career trajectories?
So, I think it's kind of hard to tell what area is kind of in need in your field when you're first starting out. Everything is of interest, and so it would be kind of difficult for me to say you find a good mentor, because that's kind of a little bit of a random event, I think, for some people. And so I would say try to align yourself with people that encourage you to pursue research and are not just your mentors, but actually potentially your sponsors, which I think is a huge thing in terms of trying to find your place as a staff potentially, right? And so those are the people that will advocate for you and will kind of guide your career in some ways in terms of maybe providing some direction as to what is needed within your area, like the hospital or locally, or from a job prospect point of view, which I think is not necessarily why you should be doing certain kind of training. But if you have an interest that encompasses 4 different things, and you're trying to decide which one of these 4 things may be the best one to pursue, you might need somebody with a little bit of a bird's eye view to give you some advice, which I think is helpful in a lot of ways. But yes, things like research and getting involved in committees and other things, if there's any time for that, are helpful from a career point of view to kind of help open up doors, I feel. But research mentors and doing different kind of projects, I think, is a good opportunity for people to get to know you, and you would probably give the same advice to medical students or undergraduate students, right? I think it's just like an opportunity to give you expertise in a specific area, and then that you basically develop hopefully a deeper relationship with regards to a supervisor that can provide guidance from a career and as well as a research or academic point of view.
Yeah, and it's absolutely vital, and it's great that you've mentioned the difference between mentorship and sponsorship, and
Mhm.
the fact that sponsorship should be as big a focus as mentorship is for early career and
Yeah.
younger folks.
It's huge. And I don't think I really recognized the difference until I was a little bit deeper into it. But yeah, your sponsor is a little bit more than your mentor, because they would like stick their neck out essentially for you. So I think that's what everyone hopes to find, right? I don't know how to suggest to find somebody like that. It's sometimes not as easy as one would assume.
No, that's absolutely correct as well. But it's good to know what to aim for and what to look for, and that's what we're trying to provide here, just sort of advice. But of course, the realities differ from angle to angle,
Yeah,
from
right.
place to place. Well, that concludes our interview. Once again, I'd like to thank our guest today, Dr. Christina Luong, for the informative and fascinating talk with us regarding novel approaches for delivering medical diagnosis and care for patients. On behalf of our director, Dr. Emilio Alarcon, and the whole BEaTS Research Radio team, thank you for tuning in. Don't forget to subscribe to our YouTube and podcast channels, and we'll see you again soon with another Science for the Community episode. Until then, stay safe and heart healthy.